I want to welcome everybody to another Collective Masters Live. We're doing a series of wellness clinics, and I'm very excited to introduce a lovely young lady, Dr. Jessi Figlewicz, who's going to go ahead and give us some information on ear health and how loud we should be listening to our music. So put your hands together for Jessi Figlewicz.
All right. Thank you so much for that super warm introduction. Like Rich said, I'm Dr. Jessi Figlewicz. I am an audiologist. So my main focus in my career is to diagnose and go into hearing loss a little bit, and then talk more about noise exposure and also about hearing protection. That's a huge factor, especially with musicians, engineers, producers, which are obviously pertinent to what most of you guys are doing on a daily basis. So we'll very much get into that. Please ask questions. Some things we'll talk about pretty heavily, others we'll kind of briefly discuss. So if you want to get more into it, please ask questions and share, and we'll get in through it together. So a little bit more about me. I was born and raised just outside of Chicago. I'm really a Chicago girl in the end. I went to Columbia College in Chicago to get my undergraduate degree. My focus originally in undergraduate was in audio arts and acoustics. I thought I wanted to be a sound engineer. That's what I initially thought I wanted to do. I took an acoustics class while I was at Columbia and learned more about the ear, and I fell in love. I always wondered how people got into these weird specific anatomies as doctors. I get it now. I was shown a model of the ear, and I remember I left that room, I called my mom, and I'm like, I think I want to do something with ears. So I subsequently went to University of Massachusetts in Amherst. That's where I got my doctorate. And I've been practicing for just over 10 years now. I started out in a hospital. I migrated to ENT private practice, ear, nose, and throat, otolaryngology, and now I'm in purely audiology-based practice. So again, my concentration is specifically on diagnosing and treating hearing loss. I got away from the nose and throat stuff. I moved to New York this past March, so I haven't even been in New York for more than a year, and I'm currently working at a private practice called Advanced Hearing Center. We have locations all over Manhattan. I'm mainly on the Upper East Side and in Chelsea, and we have some Long Island offices as well. And to get more personal, from a musical standpoint, I do have kind of a musical background too. I played French horn for many years, and I also participated in drum corps, so pictures of me in drum corps. I was with the Blue Stars and then the Phantom Regiment. I played mellophone throughout my drum corps time, essentially a larger trumpet with a mellow sound. And then in my off time, I enjoy hanging out with my cats. That's Marbles over there on the far right, Nugget here on the left, and my parents. We hang out as well with the Mandalorian. It's pretty cool. So yeah, I have a little bit of a musical background too. So as I just said, I kind of moved to this area from the beautiful suburbs of Leominster, Massachusetts, right? Very quiet, not a lot going on as far as vibrancy, nice suburb. One thing I noticed when I got to New York, which maybe is obvious, but really when you're living in a suburb like where I was, it's quite quiet, right? So one thing I noticed was the noise, right? We're surrounded by it in general, but especially here in New York City. Subways, traffic noise, street noise, right? Any bar or restaurant you go to, at this point, sometimes a little bit outrageous, clubs, DJing, all that stuff, it's just surrounded by it, cacophony of sound. So like I said, obviously this affects people in the suburbs too, but I feel like more so here being in a big city, we're just really surrounded and saturated by noise, and I don't know that we all have a deeper understanding of what that means and the implications it can have on your ears and your hearing. So what I want to talk about first before we get into anything else is how do we hear, right? Look at this thing. This is your ear, right? It's not just holes in the side of your head. There's a lot going on in this system, and I want to kind of break that down a little bit so you guys can understand what it is that's going on at any given moment as we're picking up sound and kind of encoding it. So the ear itself as a space is kind of sectioned into these different areas. You've got three specific sections: your outer, middle, inner ear, okay? Outer ear, relatively obvious. You've got your pinna here, which is all these different folds and cartilage, and you've got your earlobe as well, and then your ear canal, right? Middle ear, that includes our eardrum, tympanic membrane, and then you've got these three little bones. You guys probably learned about them at some point when you were young. They refer to them, I believe, as the hammer, anvil, and stirrup, maybe? But really it's called the malleus, incus, and stapes. So that's your middle ear, kind of categorically speaking, and then this is your inner ear. mainly your cochlea, right? That's your hearing nerve itself, and that's really the section we're gonna kind of focus on pretty heavily. But I just wanted to make sure you all understand, again, there's these 3 specific sections, and they're all responsible for certain parts in the transmission of sound. So there's 3 real stages of transmission when we're talking about hearing, right? Stage 1, modification of the acoustic wave that we're receiving from the outer ear. We get that wave, into our ear canal, goes to the eardrum, and it variates in its air pressure, right? And there's vibration involved too. So stage 2, conversion and amplification of that modified acoustic wave to that vibration of the eardrum. These vibrations are then amplified by these 3 little bones, those ossicles we were just talking about. And that's, again, all in the middle ear. And those then relay vibrations to the inner ear. Those vibrations from those middle ear bones are transmitted as wave energy through liquid in our cochlea or inner ear. And then from there, that mechanical movement of the wave gets turned into nerve impulses that will travel to the brain, right? Our brain is ultimately what perceives and makes sense of all the stuff that the ear is initially starting. So acoustic, outer ear; mechanical, middle ear; electrical, inner ear. Pretty crazy, right? Come on, pretty crazy. So this is essentially the same thing. I just kind of liked how it was simplified a little bit more, and it simplifies what I just said a little bit better. So hearing begins when sound waves enter the outer ear and travel to the middle ear, right? Acoustic signal. Sound waves then cause the eardrum to vibrate. And again, those 3 tiny bones kind of pick up those vibrations, they amplify, and then that passes along to that inner ear cochlear system. That cochlea then is covered in hair cells, which we're going to talk about as well in a second, but those hair cells are what are really decoding the different frequency responses. So that's kind of, like I said, a more simplistic way to look at it. So this is the kind of the coolest part. It's a little nerdy, but I think it's pretty awesome. So there's this concept in our cochlea called the traveling wave, right? We know there's all these different frequencies that we're able to perceive. How does our ear know what to perceive and when and all that stuff? So I'm going to read this to you, but I'm going to explain a little more. So the cilia of nerve cells in the inner ear respond to the location of movement of the basilar membrane, and depending on their position in the decreasing radius of the spiral-shaped cochlea, they activate the auditory nerve to transmit information that the brain can then interpret as pitch, right? So if you look at the cochlea, it's like this snail-shaped kind of looking guy, right? If we were to unroll your cochlea and just stretch it out straight, it would look like this, right? From your base to the apex. Again, if we unrolled that and looked at it in a straight line, you can see that we encode frequency based on where that sound wave is interpreted essentially in those hair cells, and that's what then goes up to our brain and says, okay, this is a 4K signal, 2K, right? And again, from the base, which is the beginning of the cochlea from the middle ear space, that's where those higher frequencies are encoded. From the lower frequencies that are at the apex, really curled into the end there of the cochlea, okay? We're gonna kind of talk about this a little more in terms of how that pertains to hearing loss in just a moment, but pretty cool concept, right? As far as how we decode these different frequencies and pick them up in our ear. And not for nothing, but the other thing I like to think about is, this is simplified, right? Individual frequencies. That's we don't just hear in individual frequencies, right? Music is complex, speech is complex. When you take this and extrapolate it to just conversational speech, again, music, anything, it's pretty crazy that your ear can decode these things as quickly as it can, in that complex way. So I think it's just take a second to appreciate your sweet, beautiful cochleas, because they are really working hard for you every day of your life. Even in ambient stuff where no one's speaking, they're still engaged in kind of interpreting the environment around you. So what causes hearing loss, right? That's the big question. There's a couple of things that we can talk about here, and we will, about what can cause hearing loss. Again, my main focus is going to be on the hearing nerve itself, but I think it's also important to understand that it's not just your hearing nerve that can be affected. There are other things that can cause hearing loss, and hearing loss itself, it's not just a blanket term. You don't just have hearing loss or you don't. There's different kinds of hearing loss. So there's 3 types, really, in the end of hearing loss, 3 types of classifications, if you will. So number 1, sensory neural hearing loss. Permanent hearing loss caused by damage to the inner ear or your hearing auditory nerve, okay? Conductive hearing loss, that's another big one. Hearing loss caused by sound's inability to reach the inner ear or conduct sound to the inner ear, usually due to an obstruction, deformity, or trauma in the outer or middle ear. And then occasionally I'll see mixed hearing losses, meaning it's a combination of the two. There'll be a neurological or nerve damage component, and then there'll also be maybe potentially a middle ear issue or something obstructing, and you can have a combination of the two. In my daily life and career, what I do is I'm conducting these comprehensive exams on your hearing, and one of the things I do is determine what kind of hearing loss you've got going on. Is it sensory neural, is it conductive, or is it mixed? So again, hearing loss is not just a blanket term. There's definitely specific kinds of hearing loss. So to understand that further, I liked this graphic because it kind of helps just see it in an easier way. So sensory neural hearing loss here on the left, right? This is, again, nerve damage, permanent hearing loss. So we see that most commonly due to aging, of course. Noise damage, right? Certain drugs, they're called ototoxic drugs or ototoxicity. A lot of times, mainly in like chemotherapeutic drugs, things like that we'll see that happening. Certainly tumors in the auditory system or loud blasts or explosions can cause permanent nerve damage as well. Then if you go to the right here, we've got conductive issues. So fluid in the ears, that happens a lot in kids in particular. You're more prone to it as a child than in adulthood, but fluid, it can develop from sinus infections or allergies as well. Allergies is on there as well. Again, all these systems are connected. So foreign objects, that looks like a barbell, but I think it's supposed to be a Q-tip. I don't know, puffy Q-tip, but yeah, I've seen it. I worked in ENT for many years. We'd have people come in with, beads in their ears or pieces of a Q-tip. That's an example of someone who has a hearing loss that's conductive. It's not permanent. We can typically do something about it, but there's an obstruction going on. Ruptured eardrums, impacted earwax, man oh man, I see that every day. At least I would say like 3 out of my 12 to 14 patients I see in a day probably have some form of wax or need wax removed. So that's also a pretty common conductive issue that we see. A mixed component, which combines the two. Lots of genetic disorders have that going on, some infections and some head traumas. We'll see that kind of hearing loss happen. So just to reiterate, really all conductive losses that we see are going to be something having to do with your outer or middle ear system, right? Sensory neural, we're really looking more at the cochlea and, again, permanent nerve damage to the hearing nerve itself. So what's normal hearing? That's the big question, right? And honestly, I don't think a lot of people do know this because when I'm working actively every day, one of the things I do is make it a point to go over the audiogram with the patient. It's not necessarily something we do all that often, and I think because maybe we're all musically inclined and have audio backgrounds, it's a little easier for us to interpret. But let me just break this down for you for a moment. So this is on the left here, an audiogram, typical audiogram, you'd see in a normal hearing individual. When we're testing your hearing, we're measuring a certain frequency range, right? We typically test between 250 hertz and 8K. There are frequencies below and above that. The reason we focus on that particular area is for speech reasons. Most of the consonant vowel sounds are in that specific frequency range or range of frequencies, so that's why we kind of test that area. There is such a thing as extended high frequency testing. I don't do it very often. There's mixed bag as far as reliability of that kind of testing, but so that's why we look at this particular range. So frequency across the top and then dB or decibel level on the side, okay? Up at the top, obviously, the smaller the decibel level, the softer the sound, the larger, the louder. All of the red circles you see there are representative of someone's right ear. That's how we color code and mark audiograms. And then all of the blue X's are for the left ear, okay? Pretty symmetrical, you can see on this audiogram, which is also good. Typically, your ears and your hearing will work as a pair bilaterally, so we tend to see things be about the same from ear to ear. But again, the big question is, well, what's normal and where am I looking to fall in this audiogram? So I classify myself, and most audiologists would classify normal hearing as thresholds being on or above the 20 decibel mark here, okay? And that's across the frequency range. That's what we would really classify as normal hearing. I put this other graphic here because I think too, a common question I get from patients is, what percentage of hearing loss do I have? We don't classify hearing loss in percentages. We just don't. There's a lot of reasons for that. One being that everyone perceives sound differently, but two, all of these different frequencies, right, we can hear them, or the loss itself may be different from frequency to frequency, interoctave. So it's very hard to just say 20% hearing loss, 30%. We actually tier it into levels of severity. So you can see here on this graphic, they technically, I think, say that slight can be between 15 and 25. Like I said, I usually mark normal as 20 or above, but then you've got slight, mild, moderate, moderately severe, severe, and then profound. Okay, so that's kind of the basic classifications. So one thing I want to talk about first before we get into the noise stuff, and there's a reason for it, is age-related hearing loss. It's referred to as presbycusis, okay? Extremely common. I probably see at least 4 to 5 patients a day who are suffering from presbycusis. It is a bilateral age-related hearing loss, and presbycusis literally means old or elder hearing. So it's genuinely just baked into us genetically that as we get older, yes, we tend to lose our hearing very slowly and progressively over time. It's estimated that to affect approximately 2/3 of Americans age 70 or older. So it's a problem for a lot of people. The hallmark of presbycusis is the impaired ability to understand specifically high-frequency components of speech. It becomes noticeable typically around age 60, though I will say I feel like I've seen it much earlier on. I would say around like 50 or older, and it does again progress slowly. One of the trickiest things about age-related hearing loss especially is that it again happens slowly over time, so patients and people's perception of it happening is not there. Your brain acclimates to hearing with a little bit of hearing loss. So that's like I said, one of the tricky things about identifying it yourself that you're having that kind of a problem. And there's a reason I'm talking again about this age-related factor, and we'll get into it in a minute. But so this is what presbycusis would look like. So when I have someone coming in who's maybe like in their 70s or older and has some hearing loss, this is the kind of the classic audiogram I would expect to see, right? So if you think back to our normal hearing, right, we were kind of falling around this range. So you can see now in the frequency range here from 250 to 8K, we're starting out a little normal, and then gradually, as I get higher in frequency or pitch, you can see this person's hearing and hearing loss really start to develop, particularly in this high frequency range. It slopes. It's not a precipitous slope, but it kind of gradually slopes down. There's a reason behind, too. I think a lot of people may think that we lose hearing in low pitches first, or how does that work? We technically speaking, at least with age-related loss, and in general, with a lot of sensory neural losses we'll see, it tends to be from the high frequencies backwards. So just so you know, that is a normal shape, and that is how it happens. The reason behind that has to do with this graphic here. It's a little complex. It's called the tonotopic organization of the cochlea. So it kind of goes back to that traveling wave slide I was talking about, but if you look at, it's probably hard to see here, but the curl, again, or the spiral of your cochlea at the base, and again, this base area is where your middle ear bones are kind of playing a role in sending the message along, but in this base area and then moving along, you can see this is where we start to pick up these higher frequency sounds, right? As we get spiraled into the more kind of tucked away part of the cochlea, this is more of our low frequency range. That's why when, especially age-related again or other sensory neural losses, we'll see the loss start to show up in the high frequencies first. They're the most exposed and susceptible. Those hair cells are the ones that tend to get damaged first because of where they're organized in our cochlea. So we got age-related. We did that, that's established, but what about noise-induced hearing loss? What's the difference, right? So that's, again, presbycusis, but what if someone comes in and they just have a lot of noise exposure, but maybe they're not even necessarily older in age, right? So this is what I tend to see in noise-induced hearing loss. It is recognized typically on an audiogram as a specific and pretty definitive notch, and it's generally around 4K. I've seen it in other places too, but it really does tend to center around that like 3 to 6K region. And again, this is like classic. We actually know in our field as a noise notch. And again, it's something I expect to see if you have a lot of noise exposure in your history, but this is, you can kind of see the difference actually I want to show. So age-related, right, gradual kind of dip down, noise exposure, distinct notch. We also tend to see in noise exposure, interestingly, that it comes back up a tiny bit in that like 6, 8K region. It doesn't stay that way forever, but that's what we tend to see as far as the shape is concerned. So the reason I think it's important for you to understand the age-related and then the noise-induced hearing loss is because, okay, the age-related one, we're all gonna get old, right? We can't stop it. We have no control over that situation. We are all going to get older. You never know. Fountain of youth, where it at? You're not sharing with me? It's ridiculous. But seriously, like I said, we can't control it, right? And like I said before, genetically speaking, it's baked into our code as mammals that we're just all, as we get older, going to have a little bit of hearing deterioration. What we can control is, a little bit at least, is the noise factor, right? That's something that's actually a controllable metric. So that's why I wanted to combine those two. So what happens when you combine the two, right? Say you're someone who has a lot of noise exposure and now you're kind of getting up there in age. This is the kind of audiogram I might expect to see on someone who has presbycusis, but also some noise-induced hearing loss. You can see now how in the low frequencies even, things have come down a bit. And the notch itself isn't as severe or intense. It kind of, evens out a little bit, but you can still see this really significant dip in high frequency hearing in particular, right? The other big thing, and we're going to get into this a little bit as well, but anatomically, noise exposure may lead to damage and subsequent loss of spiral ganglion neurons. So we're going to talk about the hearing nerve and the hearing hair cells themselves too, but it's really, there's a neurological component of your brain involved too that I think, well, I'm not going to dig into it too hard, but it's just important for you guys to understand that it is your ears, but it's also your brain playing a part in all of this. So, kind of to reiterate what I said, but I like this image because it kind of shows you, okay, here's a healthy hair cell in your cochlea, here's a damaged hair cell inside your cochlea, right? And the other big issue is that when you damage these hair cells, they do not regenerate, right? That's the big issue, is in some birds and certain fish will see that happen. In humans, it does not happen. So that's why I get kind of on my high horse about protecting your hearing and keeping things intact, because once it is gone in terms of the damage that's done. So like I said too, as far as neurologically speaking, the damage to these hair cells, it does affect how we encode sound, but it also directly affects the auditory nerve to the brain, those signals and those synapses, right? Like I said in this thing, beyond the hair cells, there can also be loss of synaptic ribbons and or neuronal loss. That leads to problems like tinnitus, ringing in the ears. That's a very prevalent issue, with or without a lot of serious hearing loss. And also a lot of difficulty communicating in background noise in particular. If your cochlear nucleus is not fed properly, at the beginnings and ends of auditory signals become compromised. That's why too, as people get older or with any kind of hearing loss, they'll ask for repetition, right? In background noise in particular, they'll have a much harder time because of the signal to noise ratio. There's lots of factors, but like I said, part of it is the hair cells themselves, but there's these synapses and stuff that start to get affected too. So it's pretty intense. So in terms of how this will impact someone communication daily, not in the science-y brain way, but general lack of clarity, right? Significant deterioration in word recognition and speech understanding. When I test a patient's hearing, I am doing the audiogram and the beeps, yes, but the other part of my testing is to do speech testing. We read off lists of words to patient that were really specifically designed to sound like other words of speech so that we can assess. And again, in hearing loss, what we'll tend to see is this pretty bad degradation of clarity and speech understanding. The development of signal-to-noise ratio loss. Again, this results in extreme difficulty in background noise. A lot of patients I test too, especially with those higher frequency losses, they do pretty well one-on-one. They don't necessarily have a hard time. It's when they get into the restaurant, bar, noisier space where they're like, okay, the breakdown really occurs. Reduced dynamic range. That can lead to hyperacusis, which is a reduced tolerance to sound. It's very interesting. When I see someone, especially with severe to profound hearing loss, their perception of what is comfortable, versus what is not comfortable, is extremely compressed. So you'll play, an 80 decibel tone and they're fine, but then if you creep up to 85, they are literally jumping out of the chair like you blasted them with a cannon. That is reduced dynamic range right there. Normal hearing individuals, we're lucky because for us, we just have a larger differential between what's uncomfortable and what's comfortable. So. Again, potential onset of tinnitus, that's a big one as far as just a symptom that can be produced from lots of hearing loss or even mild hearing losses, and it can just psychologically have a lot of impacts on patients. And then diplocusis, which is the perception of the same sound differently in either ear. That one's pretty rare. I don't see it often, but I have seen patients who have that going on. Not to mention the social and cognitive effects. I'm not going to get into that too much today, but there is a lot of work and study being done right now actively on hearing loss and cognitive decline. Those two things are very much connected. There was just a study published this last spring in The Lancet called the ACHIEVE study that really looked at cognitive decline, particularly Alzheimer's, dementia, that kind of stuff, and again, how treating your hearing loss can actually help in some ways prevent that cognitive decline or at least slow it down significantly. So like I said, I'm not going to nerd out and get too into it, but just some implications that all this hearing loss can have on you as far as daily communication and effectively and happily quality of life, right? So what do we do? What do we do about this? How do we move forward from here, knowing what we know now about hearing loss? I kind of chunked it into 3 sections. 1, educate yourself, which we kind of just did, but we'll do it more. Assess, and then protect. So how much noise is too much noise? So there's technically 2 different standards. One is established by NEOSH, one is by OSHA. NEOSH is really more of a research and education institute. OSHA creates and enforces regulations from a federal level, but you can kind of see on this graph here. So your time to reach 100% dose, meaning the most exposure you should have. So 8 hours if you're in 85 or 90 dBA according to NEOSH and OSHA and so on and so forth. I'm not going to necessarily read through them all, but I think too, it was funny. I was going over this with my partner earlier a couple nights ago, and he was saying like, oh, it doesn't, all right, 4 hour, 88 dB, that doesn't see that bad, all right. I think the difference is that most people now don't understand when you're going into certain environments, how loud is it actually really in the end, right? Because maybe we think, oh, that's all right, 88 for, but when you actually go into a club in New York, it's well beyond, an 88, 85 dB situation. And frankly, most people going into clubs probably aren't going for only, 30 minutes, an hour. They're probably there all night. So it's something to consider when you put it into perspective, real life application. So you guys know too, these 2 entities, they do share research. They're not associated with each other, but they do share research. So it's not like they're competing with each other to prove who's right or wrong. It's just, there's just 2 different standards. I feel bad because it's going to be hard to see for you guys from far away, but just to give you some perspective and put that to light. So I like this visual because it kind of shows you, okay, here's some examples of healthy dB levels and those kinds of familiar sounds. And then when we start to creep into not so good for you, right? So we got here, ticking watch, 20 dB, all right? Background music, light background music, 60 dB. Conversational speech is usually going to range between like 50 to 65 decibels or so. It's when we start to get into this region here. This says too, sounds above 70 dB are harmful. Yeah, like I said, we kind of starting at 85 start to get really worried, but just to again give you some perspective from the slide before. City traffic, from inside a car, 85 dB. Okay, that's already atrociously loud and you're inside a car. This one killed me. Nightclubs and bars, on average, 105 to 110 decibels, right? A trombone, a dog barking in your ear. I don't know why you'd have a dog, but 110 dB, right? A gunshot, 140 decibels. But like I said, especially that nightclub one, places like that we may tend to go in New York, 105, 110 decibels. If we go back and look, 15 minutes. That's what they are recommending, that you should be in an environment like that for no more than 15 minutes to reach the 100% dose that's going to cause a problem and potential damage, right? It's not to fearmonger. I just think it's important we understand these concepts and again, have awareness that when we go into these spaces, we may think, oh, it's not that bad, but it's probably louder than you actually realize. You also, again, your brain, you kind of acclimate to the sounds and how loud things actually are. It's why when you leave too, things are, kind of muffled and unclear. So I think it's important you grasp where you're going and how loud the space you're going to actually is in the end. This is, again, really hard to read for you guys, but I found this because I liked it. It was more of a classification of not just familiar sounds, but specific to instruments as well. They didn't put guitar on here, but acoustic guitar clocks in around 87 dB. The range is pretty great, but for example, flute, right? You're going to average 92 to 103 decibels. If you're playing the flute actively pretty often, that could potentially lead to some significant hearing loss, or at least maybe a little noise notch. So I have all these slides. If anyone wants them for later, I'm going to leave my email at the end and my contact info. So if anyone wants any of these slides for reference, let me know. I'm happy to provide it. So the moral of the story, if we know how loud is too loud, we can make better decisions for our oral health, right? So get off my soapbox. So now you're educated. What do you do to assess, right? Number 2 was assess. 2 things, I kind of had 2 branches to this pathway. 1 is assess your environment. 2 is assess your hearing. So how do you assess your environment? So no, you're probably not going to walk around all day with a dB meter in your purse or bag. I get that. But we now know, right, the dB level of some of these familiar sounds as well as what's considered dangerous. Now we apply it practically. We live in 2024. Pretty much everyone has a smartphone. Most smartphones now have something built into them that will assess an environment and let you know if you're somewhere that's maybe a little bit too loud, right? So if you don't already have that stuff activated, do it. It's a super simple thing you can do to just let you know, hey, you're somewhere that's a little bit loud. Headphones will do it too, I think, at this point when you pair it up to your phone or anything like that. So just be mindful of that. And when it's alerting you, try to do something about it versus just going, okay. This app, the Sound Level Meter app, this was developed by Neosh, so I just strongly recommend it. Again, versus having a dB meter in your bag, this is a much easier way to do it. If you really want to get into it and kind of assess the environments you're in, you can use apps now that are actually pretty reliable and decent to assess the decibel level of a given situation. We're going to get into this more in a minute too, but wear effective hearing protection when it may be warranted, right? So we'll talk about that more, but that's certainly another thing you can do to really help yourself out. Assess your hearing. Hearing care is health care. I think in general, it's kind of forgotten as we get older, especially. They test us maybe when we're kids. You do the little 4th grade raise your hand thing, but beyond that, it's not really focused on much until it becomes a problem later in life. So especially being musicians, DJs, engineers, producers, go get your hearing tested. It does not take very long, and it really is important to establish a baseline. Like I said before, the other tricky thing about hearing loss is it's not typically sudden. Here or there, I'll see cases of sudden hearing loss. It is not very common at all. It's generally a gradual, slow progression, and so because of that, you won't necessarily know that it's going on. So like I said, establishing a baseline now, even if you think you're hearing well, essential, right? Your ears are your instruments in the end. They're really what's doing all the work for you. So I recommend an annual hearing test. You don't have to do one annually if you don't want to, but I do recommend it annually. I consider it like part of a physical. It's something you should do every year. If my patients come in year to year and their hearing is normal, eventually I'll tell them, okay, if you want to do every 2 years, that's fine. We'll just continue to monitor. But typically your insurance will pay for it as well. So I just strongly recommend going and getting your hearing tested. I kind of alluded to this, but if you do think you had a sudden hearing loss, you need to contact your primary care or an ENT, and you need to get your hearing tested immediately. Like I said, it's not common, but there are rare cases where it's usually viral. Some kind of virus comes in, attacks the hearing nerve, and we'll see sudden losses, and usually, again, unilaterally in one side. They can be mild, they can be very significant, and they will happen overnight. So I don't, again, mean to fearmonger, but if you ever think you may have a sudden loss, don't wait. Go immediately contact your doctor and go get your hearing tested. That includes, too, a sudden onset of vertigo or tinnitus. If anything like that is happening to you, definitely reach out to your medical doctors and get hooked up with an audiologist who can test your hearing, and then you'll likely see an ENT from there. And because I can't reiterate it enough, wear effective hearing protection, right? That's the key, effective. So protect your hearing. That's kind of my last little bullet as far as what we can do. I purposely put all of these different examples because obviously we all know there's a lot of options out there for hearing protection. We're going to get into it in a minute here about why I prefer one over most others, but in the end, any hearing protection is better than none, right? So it's not like I'm saying don't ever wear foam plugs, they're terrible. They're fine, but there's reasons behind there are other forms of hearing protection that are just more appropriate and really just will better protect your ears and your hearing over years, right? So this is a big one, understanding the noise reduction rating. I'm sure you guys have all bought or gotten a pair of some kind of plug or muff, what have you, and you'll see something like this typically written on it. It's the NRR, the noise reduction rating. This one says 33 decibels. That's pretty good. It's not bad at all. That's actually really good. So that rating, it's a common method for expressing the amount of noise reduction, right? It usually ranges from 0 to 30, but you'll see, 33 variations on that. But again, we see this all the time. Here's the caveat. So, and then you think in your head too, like, oh, great. So if I'm going into a 95 decibel room and I'm wearing these 33 NRR plugs, then this is where I should be, right? Like around 70, so, right? No. That actually isn't true either, because the way we calculate this NRR, that there's some stuff that goes into it scientifically based on decibels and how we kind of encode that. So just so you know, that rating isn't actually fully true, but this is the big one. So that rating is based on a laboratory test where the hearing protection device is properly fit, right? So they're kind of doing it on a model. So it's ideal. Ideal circumstances, it will be a 33 decibel reduction. OSHA's experience has shown that the hearing protection device seldom reduces the decibels by the NRR value indicated. They recommend applying a 50% correction factor. That's crazy. That's crazy. That's basically saying that that label is kind of a lie, right? But it's again important you guys know that, because how would you know to go in and not see that label and think, oh great, 33 decibels? But a lot of it actually ends up being, again, too, user error, right? I kind of put this up here on purpose so you can see, like, there's all different methods of how you, and again, granted, this is a foam plug, but like, that's just terrible. That's not helping you at all, right? We're getting there. That's really what you're looking for. But again, there's so many variations in terms of how you can get that thing in your ear, the way it's fitting, how it's sealing your ear canal in that space. So that's really, in the end, too, part of the reason that NRR rating is only kind of reliable. A lot of it, again, is user-based. So for me, I'm obviously an audiologist, so I make these all the time, but custom-made plugs matter. They really do. And it goes back to what I said about that rating being not accurate because of the way it fits, right? The beauty of a custom-made musician's plug is that we make them by taking impressions of your ear canals. Because of that, they're anatomically made for you and you alone. They're not going to fit anyone else's ears. They're going to fit yours. It means we're getting an adequate seal around your ear canal and the space. So we're really giving you good protection, which already gets rid of a lot of the issue we were having with those foam plugs. Honestly, even like a lot of my patients come in and they have the eargasms, the sensophonic, all that stuff. It's not that they're bad. Again, it's not to imply they're bad. It's just that because they're not custom made for you, there's really no guarantee that they're actually protecting you as much as they say they are, right? Custom plugs, we can be a little more confident in that NRR rating because they were made for you. The other beauty of a musician's plug, at least, and again, I know they make these in this way, even with those flanged, non-custom ones, but because these are custom, you'll get even more benefit out of the filtering so that we're not occluding you too much, we're not compressing sound too much. You're still gonna get a good mid-high range definition and better fidelity with a custom musician's plug versus your foam, muffs, things like that. And improved comfort equals improved acceptance. Like I said, the other big one is, and especially here in New York, I feel like people don't really wanna wear it, right? That's a big problem, but you don't want to because it takes away from the experience, right? Or you can't communicate with your friends, things like that. If you get something like a custom plug, it's not uncomfortable to wear. It's, again, made for you, so it slips right in. There's really no room for user error, and it just means you're gonna wear them more often, probably more often than you would a foam plug, again, or anything else like that. Your ears are like snowflakes. No two ears are the same, right? And I sounds cheesy, but it's true, right? And that's the other reason I think it's kind of crazy that we would think a foam plug will be fine for everyone, because look at your ears. Every single person's ear anatomy varies so much that there's just no way to assume that, again, something non-custom is actually going to protect everyone in the same way. So what are my take-home messages? The auditory system and how we hear is extremely complex. I said it at the beginning, but these aren't just holes on the side of your head, right? Your ears collect a lot of sound. We talked about that process, and then your brain ultimately makes sense of it. It's a neurological function of your brain. Noise-induced hearing loss can directly impact hearing, specifically, but not exclusively, in the high frequency range. Remember that. Make sure you educate yourself on safe versus unsafe noise levels. Assess the environments you're in. If you are spending a lot of time in noisier spaces, it's understandable. Again, occupationally, a lot of you guys probably are. In that case, then, make sure you're understanding what that sound level, noise level is like, and protecting yourself appropriately. Assess your hearing too. I know I already said it before, but I stress that. And don't take an online test. That is a huge pet peeve of mine. An online test has zero accuracy baked into it. You got to contact an audiologist and get a baseline hearing test in a comprehensive way, not just through headphones on your computer. When I see my patients, I take them into a sound-treated booth, and it's intense. It's not, again, like you're wearing headphones plugged into your computer. So definitely contact an audiologist. And again, protect your hearing with adequate and properly fitting hearing protection. And just be mindful of how long you're in a space that's very loud for as well. And I wanted to mention this. Again, it may or may not apply to you depending on what you do, but a quick word on in-ear monitors. I do not personally work with them all that much, so I'm not by no means a pro, but they can truly be extremely powerful in terms of a conservation tool for musicians who especially perform live in those kinds of settings, but they have the potential to be very dangerous if you don't know how you're using them, and also training musicians to accept listening with their in-ear monitors at kind of a lower volume. It's tough, but if you can train them correctly, even making like 1 or 2, 3 decibels down, it can actually make a huge difference in terms of you reaching a kind of a final unhealthy dose level as far as noise is concerned. So, like I said, I'm by no means a pro or an expert at in-ear monitors, but I did want to mention that because it can be pertinent to you guys. Got some references, and you guys have questions? I know I kind of got pretty nerdy with it, but tell me what you want to know. Anything? It was pretty intense, I know. I got kind of into the brain and stuff, but.
Club in London, Coco, and I was watching a DJ set, and it was just so freaking loud. I took out the app that you said, like I had it. It was 117.
That's insanity. But that's my point, is like, we don't necessarily know when there's not a sign outside the door that's like, hey, just so you know, when you come in here, you're going to be exposing yourself to an outrageous amount of noise, and technically speaking, you should only be here for 15 minutes, right? Like, it's kind of crazy, but. Yeah.
Like, that's crazy.
Yeah. I think it's getting better, though, I will say, like, and granted, maybe that's because I moved from a small suburb, so I haven't been in clubs and things like that as much, but I was pleasantly surprised when I moved to New York at how many places I went where I did see people who were younger, like our age, you know, putting in hearing protection. So I do think the awareness is increasing, but again, I think the biggest fear, too, is kind of going back to what I talked about at the beginning with the hair cells, right? Again, this is something that they don't regenerate, they don't come back. Once you've done damage to your hearing nerve, it's not going to regenerate. And again, it's the slow progression. So when we're young, you know, we're dumb. We're going to clubs, we're not protecting our hearing. It doesn't show up when we're in our 20s and 30s. The hearing loss that we tend to see from noise and age, but noise especially, it will happen later in life. It's not until you hit that 40, 50, 60 years of age that that kind of stuff starts to become measurable and really crops up. So all the more reason to protect. But all right, well, thank you guys so much. I have my contact info here. I've got my email, my phone. We have a website for my practice as well. Like I said, I'm happy to see anyone who wants to come see me for a baseline hearing test, ear impressions for custom stuff. I don't just make custom musicians plugs. I make custom sleep plugs, swim plugs, all kinds of custom stuff too. So, but like I said, just get your hearing tested too if you have not. That's important. I fit people with hearing aids all day, and I got to tell you, it's not, you know, we try as best we can, but they're hearing aids, right? Not hearing solvers. So that's my point too, is like you can imagine looking at all the anatomy I just showed you, how we're trying to emulate what the ear does with a hearing aid. It's very difficult. And there are patients who wait so long and have such bad hearing loss that even they could go spend, you know, $30,000 on a pair of hearing aids, still wouldn't necessarily make things better because things have already become so degraded and distorted. So it's just stuff to think about in terms of maybe not impacting you now, but down the line, it absolutely will. So, like I said, get that baseline. Protect your hearing. All right? Good?
Thank you.